BioBalance Healthcast, episode 133, Testosterone and the Prostate.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
This week we're going to be talking about men and the aging process of men and prostate cancer. Most of the studies and certainly the common myth in our community of men is that if you live long enough and nothing else kills you, prostate cancer will. But fortunately, studies and common myths are often wrong. And today we're going to be focusing on a discussion of the common myth and the result of a study, which was initially a study of one patient in 1940.
I know, I think that's amazing that anybody would believe anything from one patient in 1940.
Well, you know, it was a breakthrough conclusion. And the study was that if someone had prostate cancer and you gave them testosterone, that it would increase the size of their prostate and exacerbate their prostate cancer scores and increase the damage and the danger from the cancer. And so for 50 years, doctors have said, you know, oh, we can't talk about testosterone and prostate cancer because it'll cause it, or it'll cause it if you don't have it, and if you do already have prostate cancer, it'll make it worse.
Right, and so it's kind of like one of those urban myths that people know because they know. They can't tell you, they wouldn't tell you it was 1940 something and it was one patient. And there have been awards for the initial researcher, interestingly enough. But
yeah, they're entitled "Always Certain, Often Wrong."
It's not really. We're not trying to laugh about cancer. We aren't. We're just laughing that medicine would still believe something that was so poorly researched at the time,
you know,
and then made it a belief that testosterone causes prostate cancer.
It's really hard for human beings to unlearn and unabsorb a lesson that they've learned and
That's
absorbed.
your field.
It is my field, and we talk about that all the time. I mean, when you try to break habits or mental perceptions. I have a friend who all his life was severely emotionally negative about homosexuality. And in the last 2 years, someone in his life who turned out to be homosexual and who has significant meaning for him has had conversations with him that have helped him completely reframe his emotional
That's amazing,
position.
and that's
it's true.
wonderful,
I mean, I'm so
actually.
impressed with this guy and what he's done in 2 years, just in terms of being able to continue a relationship that he would have cut off. It is hard to unlearn something that you have learned. Whether you're a physician or a school teacher or a preacher or whatever, those messages that you take in growing up or becoming educated to be a professional tend to be anchor messages, and everything else builds on top of them. And so if you discover the anchor message is wrong, you have to consciously teach yourself to change that perception, and that's really, really hard.
It takes a lot of studies for doctors to actually believe the opposite truth.
Yeah.
When they have been taught a certain way. Now, when there's a lot of things that doctors can tell you that they know is true, that they know are true, then that they can't tell you what study made them believe that. Or basically they say, I learned that in residency. It's a truth. I learned it, so some doctor told me that, and so that is absolutely true. Now, in general, that's not a bad out because you can't remember a reference for everything if you're a physician.
Well, and sometimes you don't have one.
No.
I mean, it's in my field, again, it's what we call the unthought known. You know, all of the accumulated knowledge and wisdom and experience and things you've read and people that you've seen that have come through your office, and you form a conclusion. And sometimes that conclusion is a distortion. And then you have to face that, and you have to go back and reframe that, and that's a real challenge. And so what's been happening, and the reason that we're talking about this study today, is there's a Harvard physician named Morgentaler who has really looked at the research on testosterone and prostate cancer and accumulated studies from around the world that he's compiled and evaluated the data and analyzed.
And he's done his own studies.
And he's done his own studies and written a book. And he says, A, testosterone does not cause prostate cancer. B, testosterone does not make prostate cancer worse. C, testosterone will initially increase the size of your prostate. But once your prostate is saturated with the appropriate amount of testosterone, it stops absorbing it. It doesn't take any more than what it needs to maintain. And so it doesn't increase the size after the initial adjustment to the influx of testosterone. Your prostate doesn't get any bigger. You don't get cancer if you don't already have it. And if you do already have it, it doesn't get worse.
It doesn't stop growing either. That's the other thing. Okay? If you start taking testosterone and you already have cancer in your prostate, testosterone may actually slow it down. However, according to Dr. Morgentaler, however, if you have cancerous cells in your prostate, they're still there. And they may grow slower, and you may still get prostate cancer if you're on testosterone, but it does not increase your risk.
Right. And that's the piece we want you to take home.
No one who took testosterone ever got prostate cancer, that would mean it would be the cure. That would mean that would be the silver bullet. But just like with breast cancer and estrogen, prostate cancer takes years to develop. And when it takes years to develop, it is very slow. So we may not know someone has prostate cells, cancer cells. We may put them on testosterone, and years later they may get prostate cancer because they already had it. But if no one got prostate cancer, then it would be the cure. So it would be a completely different circumstance. So yes, people can still get prostate cancer if they're on testosterone treatment or if their testosterone is excellent throughout their lifetime. But it's going to be slower. It shouldn't be as aggressive. And Morgentaler believes that it's a much riskier situation to have a low testosterone than to have a high one. That you're much more at risk if your testosterone is low
which
than
completely
high.
Flip-flops what doctors have believed for more than 50 years.
I know. And trying to tell people
and to get other doctors to hear that and go, oh, that's an interesting thought, as opposed to just dismiss it and say, no, that's wrong.
Well, Morgentaler is a reformed believer that testosterone was the cause of prostate cancer. He believed that all these years. He has done more prostatectomies than any other doctor, any other surgeon in the United States.
My father used to say there's nothing worse than a reformed drunk.
Right.
Which is why he wouldn't become one.
Which is why which is why we look at him and say, wow, here's a man who has humbled himself and said, I was wrong all these years.
I want to know the truth.
I had to know the truth. I had to find it. I found it. And now I'm trying to make people believe it, but everybody is blind. It's very hard to get this message across. When patients come into my office and they say, will I get prostate cancer from testosterone? And I say, no, you won't get it from testosterone. Doesn't mean you'll never get it.
Well, you know, part of the conversation, and as a physician, you know this better than anyone, is about the level of anxiety and fear. I come in, I'm male, I'm 65. I know eventually every male gets up against this, at least from the common wisdom. So I'm going to come in and say, doctor, is this going to help me for all the other reasons that it might benefit me, but is the cost of that going to be that I'm going to get cancer? And we still tend to see cancer in all caps. All forms of cancer mean you're going to die. And that clearly is not true anymore. Most people who have a cancer diagnosis of any kind don't die from it.
That's true.
And to get that message to penetrate the cultural ethos is a real challenge. And so people come in and they talk to you and they say, well, I heard somewhere, my friend told me, my friend's doctor told him. And you're sitting there with information that you have and science and data, and they're going to want, you know, they look at that and they numb out. They go blank. And they go blank because they don't have the training to think that way.
And they're afraid.
And because they're afraid.
They're afraid. And so that's why I have many of the things that we talk, that's why we're on the air.
Yeah.
And basically, and that's why I have all the articles that we update regularly into our bibliography in our website so that we have articles that you could actually give to doctors. They can actually read them. I can't reprint them. That's a copyright issue, but I can list them and the doctor can get the articles.
Right.
So it's not like Morgentaler or I are trying to convince people to take something that would harm them. In fact, I wouldn't put my husband, my husband's best friend, all of the people that I care about,
all the men you know and love,
all the men I know,
Yeah.
all this significant men in my life, my best friend's husband, I wouldn't put them on testosterone if I was going to do something bad for them. I look at that as I'm not going to increase the risk of prostate cancer. I am going to help them with Alzheimer's, diabetes, keep them from having loss of muscle and ending up in a nursing home, from frailty. I'm going to keep them from having strokes and
it goes back to the
does
cultural
all
myth.
of those
If
things.
something else doesn't kill you, eventually prostate cancer will.
Right.
And your primary goal is to make sure that all that other stuff doesn't kill them. But you can also reassure them that testosterone won't adversely impact prostate cancer.
Right.
It
not
may
only
make it stretch out and be less damaging and give you more time if you have it. Or if you're genetically marked to get it, it won't prevent that.
Right.
But it won't cause it and it won't make it worse.
So when we're talking about this, like I oftentimes have patients that will come in and they're in their 70s, okay? And either they just started to need testosterone, they were lucky and they had a long-term high testosterone and they didn't need it, they didn't have symptoms. So at 70, I start them on testosterone. And that's a time when we stop even looking at PSAs because prostate cancer, we assume that everyone has some elevation at 70. So, but we check it anyway at the outset just to make sure that we don't have to have them see their urologist first. In any case, when 10 years later, they're 80 and they have an abnormal PSA, you have to think, we've saved them from all these other diseases. Yeah, the PSA is high. Usually they don't even get treated. Over the age of 75, they usually don't treat prostate cancer.
Yeah.
So the big fear of losing virility, losing having a terrible erectile dysfunction is not there because you don't have to have the prostate removed at that age, and because it's a slow-growing cancer, very slow-growing. So in general, the way we look at it is, with testosterone, we fear it because we're fearing ED, we're fearing impotence actually because of the surgeries, and we're fearing a cancer. But this is quite a different cancer than even breast cancer, and it's very treatable. And there are other ways to treat it besides radical surgery.
And actually, testosterone is a fairly inexpensive way to increase your quality of life while you do not jeopardize the issue of prostate cancer.
That's right.
And you can have a better quality of life as you get older for not a lot of money, and certainly it's not a painful or risky procedure, or not a time-consuming procedure, and not an expensive procedure. And cost is also a factor. Medical cost issues are things that we are all concerned about, and Kathy and I have done lots of podcasts on the topic of medical costs. And actually, we're going to segue in a minute into something else that's in the news, talking about cancer and cost and medicines and treatments. The goal is always to find the least invasive, least expensive, positive outcome.
Right.
And so you juggle the balls to say, how do we get these things to line up so that if we look at them objectively, we see the best way to go. And that's why it's important that you are an informed consumer and you have some of this information so that you can go to your doctor and say, well, I just saw this thing on the internet that said
which will
this
drive him
doesn't.
crazy or her crazy.
Oh, yeah, unless they're informed and or open to being informed to counteract the myths under which they were trained.
And there are many articles by Morgentaler and his group, and he cite in the article that we are citing, the author cites many other people who have done research on this, And the most important to me is, I always tell people, it's not the testosterone. It is the estrogen that you make out of testosterone as you grow older. Now, the issue here is you have to look at this like a pie chart. Okay, your total testosterone as a man gets older, and you're going to have to visualize this. The pie chart shrinks in size. Okay, but inside that pie chart is a percentage that's active testosterone. That's the only free testosterone. It's the only part your body sees. Your body does not see the total, it sees the free. So we've got this free percentage, and it gets smaller as we get older, as men get older, women as well. So the free testosterone's dropping, which is why we have to add more and get to a higher level to get the same testosterone that's free as you had when you were younger, which is healthy. So we can't make that piece of pie bigger. So we have to make the circle bigger to make the area the same. Okay, so we're talking more testosterone to bring you back to normal, the same free testosterone as you had in your 30s or 40s.
So as I understand this, and we've had this dialogue because I'm not scientifically minded the way you are, free testosterone is the testosterone that circulates in your bloodstream and is on call. It is ready and available to be used by the body for the things that we use testosterone for. The global or total testosterone that you can get a blood test measure of also includes what's called bound testosterone, which has already attached itself to some element in the body.
To a protein.
And is no longer available for use. It changes it from what it was into something else. It metabolizes. And so the total testosterone isn't the measure that you have to look at. The free testosterone, what's available to be used. You put this much in the body, how much are they going to actually be able to utilize?
Right, and as we age, that percentage goes down. And it goes down, that means free testosterone is the only testosterone that goes to your brain. You cannot get the bound testosterone into your brain. So you can't, it doesn't change your libido, only the free. So just consider the situation of less and less testosterone, and as we get older, so that's the risk for prostate cancer, is less and less free testosterone, but it also is estrone. Estrone is the estrogen, and that it cites this study where estrone is the key. If you can keep the estrone down. Now, what estrone is, I've used the bucket picture before. You're putting testosterone in every day into your body from the testicles or from pellets or from gels. You're putting it in, and then you can either use it, it comes out of the bucket to be used, or it gets transformed into estrone, which is an estrogen. Estrone is that hormone in men that gives them breasts, man boobs and belly fat, and makes them kind of feel tired and crying at movies and, you know, things like that. It does make you feel a little more feminine, and that's not really a good thing for a guy. So I mean, in general. So as men get older, the free testosterone goes down and the estrone goes up. So the real problem with prostate cancer, they believe, is estrogen. So the goal in treatment is when we're putting the testosterone in the bucket and then it's leaking out and becoming estrone, because so it's decreasing the total. We need to plug that up. And if we can plug that up and decrease the estrone, then the prostate's much happier. And the way we do that is we use a medication called Arimidex. It's an enzyme blocker, because there's an enzyme that takes testosterone into estrone. We block that enzyme, no estrogen. That's all we need. So that's what I do with my patients. I give them more testosterone, which increases the amount of free testosterone, and I put a plug in that bucket.
It's like a shield that you put around the free testosterone so that that it won't convert into estrogen and is still free for other uses of the body.
Right.
So
That's
it's a
exactly
selective shield.
Right.
And it protects you. And I was flabbergasted to learn that men produce estrogen, and especially as they get older, produce more estrogen and less testosterone. And so learning about the balancing act that you have to do is really, really important.
Yeah, it is. It's very important, and no one thinks about the hormone estrogen. In fact, I've been to anti-aging conventions, which is, like a new specialty. And most of them talk about estradiol, which is another estrogen, but not the key one. Estrone is the bad one, and it is more related to prostate cancer, man breasts, belly fat than estradiol is. Every man has some estradiol, and that's okay because it helps them with their bones. Testosterone is a great bone builder, and so is estradiol. And men should have a little bit of estradiol. We don't want to wipe it out, but should have a little bit to make their bones strong and keep them strong, because men have stronger bones to begin with, heavier bones, and that's also an issue with aging. We need to keep men's bones thick, just like women. So that's an important fact. You need a little estradiol, but the bad guy is estrone. So I keep that low in my patients at all costs. I use DIM as a supplement, and DIM is an enzyme blocker, but natural. It's made out of cauliflower and broccoli, believe it or not. And but fields of it in one bottle. It's not like you can eat enough of that. And so we use DIM, or we use the medication Arimidex. And I have Arimidex mixed in my pellets and in certain of my pellets, so I can choose that in patients, especially men, who have a lot of estrone. So that's how we decrease risk. We replace testosterone so the free is normal. We decrease estrone. We completely inform people that, yes, they could still get prostate cancer, but this is not going to hasten it along.
Right, or make it worse if you have it.
Right.
And I guess probably should also close by saying that when you talk about replacing testosterone, there are a half a dozen different delivery mechanisms. There's artificial testosterone or synthetic testosterone, and there's bioidentical testosterone. And what we're talking about for the optimum results are the bioidentical pellets that are inserted in the fat tissue of your hip or buttocks, because those produce a consistent on-demand supply that mimics the natural testosterone that your body makes. And so you don't have the metabolic side effects that you get with, or costs that you get with other kinds of testosterone.
And has the least conversion to estrone. So
So
that's key.
That balancing to cut down your estrogen.
Absolutely.
There you go.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter at Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Find Brett Newcomb at brettnewcomb.com.